And it's time, all our friend. Thank you for coming the 1:30 the ICC webinar. Good morning and good evening. I'm Dr. P.Y. Cho. Today is the Dr. Junior too, and myself will moderate this 1:30 webinar. Today we are so happy to invite Professor um, Abhay Datarkar from India. Professor Datarkar is a distinguished leader and academicians and researchers in dental education and craniomaxillofacial surgery in India, with over 24 years of experience. He currently serves as the dean and the professors of the oral and maxillofacial surgery at the Government Dental College and Hospital, GDCH, in Nagpur. An internationally recognized surgeon, Dr. Datarkar completed a fellowship in craniofacial surgery at the Nationwide Children's Hospital at the Ohio State University, United States, and served as the International Dental Advisor to the Royal College of Physicians and Surgeons, Glasgow. A dedicated humanitarian, he has performed over 1,500 free cleft lip and palate surgery through the Smile Train India initiative. As a prominent researcher, Dr. Datarkar has secured over Rs 4.11 crores in government grants and pioneering a patient-specific implant rehabilitations for post-COVID-19 mucormycosis. His extensive academic portfolio includes 97 national and international publications, 2 patents, and 15 copyrights. Under his leadership, GDCH Nagpur achieved a prestigious NAAC A+ grade. His contributions have earned him numerous accolades, including the MUHS Best Teacher Award and the Oral and Maxillofacial Surgeon of the Year. Today, Professor Datarkar would like to share his extensive 25 years experience to manage the patient with the alveolar cleft using the ABG procedures. By the way, we have 3 very experienced friends from the world. The first one, we invite the Professor Sukan from Mahidol University, Thailand, Bangkok. Hello, Professor Sukan. Thank you for
Hello.
coming.
Good evening.
Good evening. And the second one is Professor Tinchen Lu from Chang Memorial Hospital. Hello, Dr. Lu.
Hello.
Hi. The third one is our old friend, Professor Takayuki Handa from Iwate Medical University, Japan. Professor Handa, how are you? Good evening too.
Hi, good evening, everyone.
Yeah, thank you. So let's learn from Professor Datarkar. So Professor, please. Thank you.
Thank you so much. Can you see my screen?
Professor, you have to share again.
Okay.
Yes.
Now?
Yes, and please the full screen. Thank you.
Now it's okay? Yeah.
It's good.
Yeah.
Yes.
Thank you so much. So at the outset, I would like to thank for giving me an opportunity for this particular prestigious webinar, which is 130th webinar by Chang group. And I thank for the wonderful introduction by Professor Pang. And I also welcome the chairpersons, Professor Sukarna, Professor Lu, and Professor Honda. So whatever I'm going to talk today is my experience of 25 years in managing the patients with the alveolar bone graft, alveolar cleft with the bone grafting. Basically, if you see my journey as a oral and maxillofacial and craniofacial surgeon, as in the introduction you mentioned, I did my fellowship in craniofacial surgery at Nationwide Children's Hospital, Ohio State University in Columbus, Ohio. And I am associated with the Smile Train where I did more than 1,500 cases of the cleft lip, palate, alveolar bone grafting, secondary cleft deformities, and the other types of the rhinoplasties and the other procedures. So I'm going to share those experiences like when I was the young surgeon around in say 2001 and 2002, when the exposure was not much for such type of procedures which were limited, which were not done very commonly in this particular part of the world. And one of my plastic surgeon colleague with whom I used to work for the cleft and craniofacial work, he one day called me and he asked me, Abhay, can you do this particular case of the alveolar bone grafting? And before that, I just saw like how it is done, never assisted or done. Then I go through the literature, I read about it, I discussed with my other colleagues, and then in 2002, I did my first case of alveolar bone grafting in around 9.5 years old child, where the canine has started erupting. And so that is the journey what I am going to share with all of you today in this particular presentation. The purpose of this presentation is I'm going to present those 215 cases where the alveolar bone grafting was done, 161 were the unilateral cases and 54 were the bilateral cases. 115 were the males and the 100 were the females. The age ranging was from 2 years to 23 years. Initially, we used to do the early primary bone grafting also, but now we are not anymore doing that particular. And those patients were operated for various reasons. I'm going to speak about what were the reasons, what was the age and timing of the grafting, what types of the bone grafts we used in this particular series of 215 cases, the surgical protocols and the surgical procedures were used, and how we evolved those surgical procedures since we started doing the alveolar bone grafting for, and what were the outcomes of these particular grafting procedures, types of the grafts which we used for this type of the patients. So that is what I'm going to present in this particular, and that is the purpose of this presentation today. So if we see the incidence of alveolar cleft and the prevalence of alveolar cleft, all of you know the incidence of the cleft lip and the palate is around 800 to 1,000 in different parts of the world. So an alveolar cleft is well described in bone malformation with a prevalence of 0.18 to 2.5 per 1,000 infants. Amongst the alveolar clefts, the unilateral cleft is more common. So in my series also around 151 patients were with the unilateral cleft. And the alveolar cleft occurs in 75% of the cases with the cleft lip. So this is very common in those patients where the cleft lip is present. In the partial palates, it is usually not seen where the lip is not involved. Alveolar cleft results from the incomplete fusion of the nasal process and the oral palatal shelves. As all of us know how the cleft is formed, how the nasal process and the maxillary process, and there is a disturbance in the growth, and which results to either unilateral or the bilateral type of the cleft formation, and that will lead to the alveolar cleft also. This abnormality mainly involves the area of the canine and lateral, very common because this is the area where the fusion of the maxillary and the nasal processes takes place, and which leads to the formation of the maxilla. And sometimes it is in the central incisor. So this central cleft is very, very rare. I operated one case where there was a cleft lip in the center, which was not involving the alveolus. So it is very rare, but the clefts alveolus in lateral and the canine is the most prevalent. Now, what are the problems which are associated with the alveolar cleft? As all of you are associated with these type of the deformities, the cleft lip, palate, and the other craniofacial anomalies, everyone is known about what are the problems the patients with the cleft lip, palate, and the patients with alveolar clefts are having. So as we do the operations for the lip at say the 10 weeks, then for the palate from 11 months to 18 months, that depends upon what is the type of presentation. So tooth eruption in the cleft and the oronasal fistula is the most common issue what the patients are having if there is a alveolar cleft, especially when it is unilateral or the bilateral cleft. So there is a deviation of the alveolar segment. Usually the segment which is having the cleft, it is usually deviated and it is rotated. So the role of the orthodontist is very, very important in aligning those arches before or after doing the alveolar bone grafting. The large defects which are associated with the speech problems, because there is the escape of the air from the oronasal fistula or the oronasal communication. Usually the patients are having these problems of the speech this particular alveolar cleft. Alveolar clefts can differ in severity, but are typically associated with the deficiency of the maxillary bone. As we know that the patient with the cleft usually have the deficiency of the maxilla, which may be severe or which may be less, depending upon the type of the cleft which was present in that particular and the type of the intervention which was done. And consequently, there is no base for the dental growth or the preservation of the permanent dentition. And that is the main purpose why we want to do the grafting of this particular cleft, which is present in between the alveolus of the affected and the non-affected side in this problem. What is the purpose of the alveolar bone grafting is, what we are going to do with this particular surgical procedures, we want to close the oronasal fistula which is there. We want to stabilize the maxillary segment, and that will help us in doing the further surgical procedures like the distractions or the lithotosteotomies. And another very important is the rule of thumb is usually we have to do the grafting when the canine starts erupting at the age of 9 to 11 years, which I'm going to further talk in my subsequent slide. It also supports the nasal base. When we do want to do the rhinoplasty, usually on the affected side, the alar base is depressed. And by doing the alveolar bone grafting, we try to equalize those alar bases so that our result after doing the rhinoplasty is stable. Obviously, the orthodontic benefits, orthodontists have a major role in the management of this type of the patients, and the implant site development, like when there is a missing teeth, in many patients there is a missing tooth. So we can do the implants in this particular alveolar grafted areas after the growth spurts are complete. The purpose of the bone grafting is to mend the defect or the malformation using the tissue and the biological materials. The most commonly used is the autogenous bone graft. A clinician has multiple options of the augmentation, as we know the iliac crest, the cranium, the tibia, the mandibular symphysis, the interpositional bone graft, the guided bone regenerations, the xenografts and the alloplastic. At few centers, few studies are published in the literature where even the alloplastic materials are also used. So these are the different options which can be used for the correction of this particular cleft which is present in between two alveolus. But the most commonly used is the iliac crest and the cranium also. Cranium because it mimics the exact purpose, the membranous bone which is present in this particular part of the face. The pre-operative assessment, what we usually do is obviously the clinical evaluation, which is the most important thing. We must see the type of the fistula, then how much is the size of the cleft. Because if the size of the cleft is more than say 8 to 10 millimeters, then it is very difficult to close that particular cleft by just doing the alveolar bone grafting. So we have the different procedures which we can be which can use for closing that particular wide alveolus, and then the grafting can be done. I will show you a few cases of that also. For the preparation of the orthodontics, obviously, sometimes we need to do the alignments and then the grafting is done. And after grafting also the final corrections. Radiographic assessment, initially when we started the procedures, we used to do the occlusal radiograph or the panoramic radiograph or the intraoral periapical. But nowadays, the CBCT is the most common, or the computer tomography is the most commonly used tool for the assessment. What is the size of the defect, the type of the defect, what is the position of the septum, and everything can be evaluated. That will really help us in doing the proper surgical procedure. And the dental development assessment, that is an also very important thing in the pre-operative assessment. This pre-operative assessment also depends upon at what stage of the life the patient is reporting to us. In India especially, the patients are, once they did the primary surgeries for the lip and the palate, they usually come. Few learned patients, obviously, they follow the protocols, whatever we tell them in the beginning of their cleft surgical protocols. But there are many patients who come or who report at the age of 18 years, 14 years, And then that particular development of the dental arch is also very important while doing the assessment and the pre-operative assessment and finalizing the surgical procedure. Which are the factors that influence the success? Obviously, the timing of the surgery, the most important thing, the orthodontic preparations, the surgical techniques, what we are using. There are different surgical techniques which are reported in the literature. Then the patient compliance is another very important issue as far as the factor which will influence the success, and the cleft severity. As I told you, the wider the cleft, the possibility of acceptance of that particular bone graft is comparatively less. We need to have an excellent osteoblastic jumping distance in between the graft and the normal alveolus. So that will definitely help us for the proper take-up of that particular graft, and the bed where we are actually going to do the grafting. How we do the closure of the oronasal communication. That is also another very important thing when we are doing the alveolar bone grafting, and that has to be properly evaluated, assisted before we take the patient for any surgical protocol. Now, at our center, what were the reasons for the grafting? I was a young surgeon when I told you in around 2002 to 2007 8. So where we tried to do some primary graftings, because there were the reports which are published in the literature for the primary grafting, which says you finish up all three procedures before or during the age of the 2 years. But our experience was not good with this, where subsequently after 9 to 10 years, where the primary bone grafting was done before 2 years of the age, those patients were taken for the subsequent alveolar bone grafting at the age of 9 to 12 years. Secondary bone grafting after 2 years of the age, that is also early secondary bone grafting from 2 to 6 years, not very frequently done. The very frequently done procedure is the secondary bone grafting when the canine starts erupting, especially from 6 to 12 years. But we do at the age of from the 9 to 12 years is the reasonable time where the secondary bone grafting is done. In our series, the maximum patients underwent the secondary bone grafting, and the late secondary bone grafting, or we can also call it as the tertiary bone grafting, which is usually done after 12 years of the age. And the different reasons for this, as I mentioned, to do the final dental prosthesis corrections, to give a proper support for the LR base when we are planning the final rhinoplasty procedures, and all these things are the reasons for the tertiary bone grafting. So we did 15 patients with the primary bone grafting, 25 patients with the early secondary, around 100 patients with the secondary bone grafting, and 75 patients with the different reasons for the late secondary or the tertiary bone grafting, and this is the classification we follow as per the Peterson's principle of the oral and maxillofacial surgery. The surgical procedure for the alveolar bone grafting is very, very important. As I mentioned, there are different techniques which are described in the literature. But if you see on my screen, I usually follow this particular technique where the gingivo-cervical incisions are given around the teeth. You can see here. Then the incisions are extended along the alveolus, and then that is extended to the opposite side where the gingivo-cervical incisions are given, and the releasing flap you can see here is also given. So that will release the flap to shift it towards the size of the defect or towards the area where we are going to do the grafting. From the palatal side also, we need to do the proper reflection of the palatal mucosa so that you can get a proper palatal closure. And as also from the nasal side also, we have to do the proper reflection of the base of the nasal flaps, which can help us in getting the proper oronasal closure where the graft will not be exposed to the nasal cavity. If it is exposed to the nasal cavity, you know that it is going to get infected. Okay. And once we do the proper reflection of the mucoperiosteal flaps, as you can see here, the alveolar defect is exposed, it is visualized, it is you can do the measurements also on the scans, the CBCT or the CT scans. I'm going to show you one of the studies which we did in our in our center, where the actual size of the graft, the defect was used, that particular size of the graft was harvested. So that will help us in how much amount of the graft we need to harvest. And once you do the proper visualization of the alveolar defect, we have to do the closure of the palatal mucosa, the nasal base, and harvest the graft, and then do the proper closure. You can see here from the oral side or from the labial side. So this is the surgical procedure. The other surgical flaps, usually some people they use the gingivocervical rather than gingivocervical, the mucogingival flaps are also used by few, but we have the very good results with this particular incisions, that is which we are following since our. Now the techniques of the harvesting, as I mentioned, the iliac crest is the most commonly used. The cancellous iliac crest bone graft is the most commonly used. So there are different techniques of harvesting this particular graft, which can be used, but the most commonly used technique for the harvesting of the iliac crest bone graft is the trapdoor, where and that also depends upon. I will just you can see the different techniques of harvesting the bone grafts from the iliac crest. This is the cross-shaped approach. You can see on the lateral side we usually do this particular approach. Then the clamshell technique, where actually the iliac crest is splitted and the cancellous bone can be scooped out from that particular region. Then the trapdoor, which is the most from the lateral or the medial side, the entry is made into this particular region, and then the trapdoor and the trapdoor can be closed. And the tertius approach, where the block trap also can be used or the harvested by this particular type of. So these are the different techniques of harvesting the bone grafts which can be used in our patients. Most of the patients we did with the trapdoor, where the alveolar, the cancellous as well as the corticocancellous bone graft can be harvested. We tried the tooth as a bone graft, but the disadvantage of this particular technique is the limited amount of the graft material. So the tooth, especially the third molars, if the patient is having those, or those which teeth which we will be sacrificing for the orthodontic purpose, those tooths, they were extracted. The tooth was prepared. It is a very good autogenous bone graft material, but the only disadvantage is the limited quantity of the bone or that particular tooth as a graft material which is available. So in very small defects, this particular tooth, autogenous tooth as a bone graft, can be harvested, and we did a dissertation on this particular topic, which is also published in the literature in one of a journal of oral biology and the craniofacial research. One of my student did. The take-up of this particular tooth as a bone graft is very good, very good. It is very high in the bone morphogenic proteins and the other the growth derived factors, which are very good for the take-up of this particular. The late secondary bone grafting, especially when the chin is prominent in those patients, the bone can be harvested from this particular region, from the symphysis region or from the chin also, where the genioplasty needs to be done. So depending upon the need of the surgery, we can do the harvesting of those bone grafts. But the most commonly used is the iliac crest in this particular. So this is one of our first cases of the primary bone grafting when the child was around 2 years age. The parents were also very enthusiastic. They wanted to finish up the surgical procedures in as early age as possible. So we took this particular patient. The advantage of harvesting the iliac crest is the bone is very soft in this particular age. Okay, it is very soft. You can just even because the more cartilage is present, so you just separate that cartilage and take out the bone and then cover that cartilage so that there will not be any growth disturbance in that particular iliac bone also as the child grows. But as I mentioned, you can see here, as the child grow, what happened when we took the radiographs subsequently at the age of say 4 years, 7 years, 9 years, and after that, the alveolars, or the bone, whatever the bone which was placed over there, that automatically that usually slowly got resolved. So we have to took this patient particularly for the secondary in another surgical procedure where the graft was taken from the iliac crest and the cancellous bone graft, and then the subsequent procedures are done, and then the patient was sent for the orthodontic alignment, and the patient is undergoing orthodontic alignment, and this case will be planned for the secondary correction of the hypoplastic cleft maxilla and the rhinoplasty in the subsequent procedures. And this is the commonly done procedure, early secondary alveolar bone grafting, when the teeth starts erupting. At that time, we do this particular procedure in between the lateral and the canines. The iliac crest bone you can see here, which is harvested. This is the corticocancellous bone. We fill the cancellous bone initially, and then to support the base of the ala, we usually do some cortical bone stabilization, which can be fixed with the titanium screws also in very few cases. But nowadays we don't do the fixation. It was in the beginning about 20 years back. We used to do the fixations also, and after that you can see the maxilla become one, and the patient was subsequently sent for the orthodontic treatment, and the subsequent treatments were done. The secondary, another case of the secondary alveolar bone grafting where the teeth starts erupting. You can see here the patient was undergoing the orthodontic treatment. Here you can see the expansion of the arches was done by using the Hyrax and the other different techniques by the orthodontist. And when they started aligning that arch, the patient was taken for the alveolar bone grafting. Now it is always a debatable, especially when the patient is at the age of the orthodontic treatment, whether to do the corrections of the alveolar arches first by doing the expansions and the corrections and then do the alveolar bone grafting, or to do the grafting and do the expansions, because in few articles which are published in the literature that says that if we do the grafting first and then do the orthodontic procedures, there is a possibility of the opening of that particular alveolus. But that the decision has to be taken depending upon the age of the presentation of the patient too, and especially if the teeth are in a phase of eruption and we do the grafting at that time, usually there is no possibility of opening of that particular maxilla when we are doing the expansions by using the different techniques and the final orthodontic corrections. And you can see the finished orthodontic treatment in this particular patient, and subsequently the rhinoplasties and the other things can be you can appreciate well aligned arch in this particular, the upper and the proper occlusion correction. So a very complicated case of the bilateral alveolar cleft. You can see here, this is a bilateral alveolar cleft. So we did the bone grafting on both the sides, and then the patient had undergone the multiple orthodontic procedures. You can see for the alignments, because it is one of the most complicated case where the premaxilla is protruding, and you can appreciate here the premaxilla is protruding. So we prepared a space, then we do the expansion, and then the premaxilla was brought into the alveolar cleft, and then the grafting was done, and then subsequently the other corrections of the orthodontics. So as I mentioned, the orthodontist has a major role, especially when we are doing the alveolar bone grafting. So suggestion from the orthodontist is very important when we are planning these type of the surgical procedures for the correction of the alveolar cleft. In another case, as I mentioned, you can see here the alignment of the arches where the lateral is on the palatal side. So and the few teeth were in the cross bite also. So initially the alignments was done by the orthodontist, but there was a fistula, oronasal communication and the alveolar cleft after doing the alignment also. So we did the grafting. You can see he's the cancellous bone graft, which was harvested from by a trapdoor method from the iliac crest. The alveolus was open. It is filled with the cancellous bone graft. Usually we do the overfilling of that particular area, because sometimes the possibility of that particular graft to get initially resolved is always there when it is only a cancellous bone graft. But if it is a cortico-cancellous bone, that will be taken care by the cortical bone if it is a combination of the cortico-cancellous bone. And you can see the patient in its final corrections. You can appreciate this is the pre-operative and this is the post-operative, where the final corrections were done. The fistula was also closed, and the proper occlusion was achieved with the help of the orthodontist in this particular case. Then another case where the wide alveolar cleft, as I mentioned, more than 8 to 10 millimeters, it is not possible where the graft can be properly secured in that position, because you will not get a proper soft tissue coverage, one thing, and the amount of the bone graft required will be very high. So what we did, you can appreciate a very big alveolar cleft in this particular patient, more than 10 millimeter size. I think this was around 14 to 15 millimeter size. So what we did, we planned a tooth-borne Hyrax alveolar distractor. This is an indigenous distractor which was fabricated by my student, a postgraduate, where the Hyrax screw was used to do the movement of those alveolus on the non-affected side towards the affected side, and the alveolus, which was about 14 millimeters, which was reduced to around 3 to 4 millimeters by using that particular distraction method. I will show you the surgical procedures also. You can see the incision, then this is the osteotomy which is done. And after doing an osteotomy, the distractor was applied. You can see the sutures were placed and slowly the distractor was open. You can see here, I think 7 days, then 15 days, and then the 21 days. This is how the distraction we can appreciate how slowly the alveolar cleft is getting reduced in this particular patient. And once this alveolar cleft was reduced, the secondary alveolar bone grafting procedure was done in this particular case, where the bone graft was harvested from the chin region because the requirement of the bone graft was not very high in this case. And we can appreciate there was already a breach at the base of the nose. So we just need to close this particular defect which was present. So the graft was harvested, it was placed, and then the suturing was done. The other reasons why we did the graftings are for the dental rehabilitation purpose, where there is a where there is a cleft. The patient is already around 21 years, but the support for the implants or the prosthesis was needed. So the dental rehabilitation, the grafting was done in this particular case. And I told you, like when we do the rhinoplasty and the alar base is depressed, especially after the growth spurts are completed around 21, 22 years of the girl, where the correction was done by doing the cleft rhinoplasty. So we harvested the corticocancellous bone graft, which was used as a base, alar base support, and then the rhinoplasty was done for this. So alar base reconstruction with the simultaneous rhinoplasty. And these are the different reasons why we do the alveolar bone grafting. Another very important is for the placement of the endosseous dental implants. Okay, so when there is a missing teeth, so and the bone is not there, and the child is already grown, after growth spurts are completed, you can see after alignments of the teeth, the grafting is done here, and after 6 months of the grafting, 2 implants are placed, and the prosthesis is given to this particular patient. So the another use of doing the alveolar bone grafting is for doing the endoosseous implants also. So these are the different reasons where the alveolar bone grafting is needed, especially as I mentioned, as a tertiary type of the alveolar bone grafting process. Okay. Initially, we used to do the measurements by using the Kindle's volumetric assessment, which was done in the 48 patients which were involved, because when we started doing this procedure in 2002 till 2010 or 12, the CBCT or the scans were not readily available at our centers. So the two-dimensional evaluations were done where the occlusal radiographs were taken, and by using this Kindle's volumetric assessment, you can see here the pre and the post, where the uptake of the graft was evaluated, and the scores were score 1, which was very high in 73% of the patients, and 10 patient 19 was the score 2, and the 4% of the patients were the failures, and the 4% of the patients. So what is score is when there is a uptake of the graft which is more than 75%. What is score 2 is about 50 to 75% of the uptake of the graft. What is score 3 is the less than the 50% of the graft, and score 4 is the no bone bridge is formed in between the two cleft alveolus. Okay, so this was the scale which was used as a volumetric assessment, but this is the disadvantage is this was a two-dimensional measurement where the three-dimensional picture cannot be visualized. So we did a comparative study of the assessment of the cancellous and the corticocancellous bone graft in the management of the unilateral alveolar cleft using a cone beam CT, a randomized control trial, where the three-dimensional assessment was done in all those patients. A volumetric assessment of the alveolar bone graft done was by using the 3D CT scans, and the of course the 2D sagittal axial and the coronal views. Efficacy of the cancellous and the corticocancellous bone was measured, and observed the amount and the architecture of the newly formed alveolar bone. So this was one of the dissertations which was done, and the access to the ease of harvesting, handling, and the accuracy in filling the complete unilateral graft, and evaluate the volume of the cancellous and the corticocancellous anterior iliac crest bone graft through the use of the cone beam computed tomography. I will show you how we evaluated that. Okay, so this is one of the case where the actual measurements were done and how much amount of the graft was required in a cubic centimeter was measured by using the different scans. So where the volumetric assessment was done, and you can see in group one where the cancellous bone was harvested, you can appreciate here. Suppose we need, say, 1 centimeter cube of the bone graft or 2 centimeters cube of the bone graft. So the assessment was done. Then that particular amount of the cancellous bone was harvested. It was measured by using a three-dimensional the syringe, and then that was particularly inserted at the site of the where the bone needs to be the what we call it as the recipient site, and the closure was done. And the another was the corticocancellous bone graft. You can see here. So the same way we did the measurements, the how much amount of the corticocancellous bone graft was required, then that was an en bloc technique, and that was the group two. So in group one, we did a cancellous bone grafting, and in group two, we did a corticocancellous bone grafting. And you can appreciate these are the patients which participated in this particular group one and the group two in this particular study. And I will show you the ease of harvesting and handling was very good in group one because it was a cancellous bone graft where cancellous bone can be very well adapted in whatever the size of the alveolar cleft is there. And the adaptability was moderate. Ease and harvesting of the corticocancellous was comparatively less with the in a group two. So accuracy of the graft filling was very good in group one. In 9 patients, it was adequate, and in 10 in one patient it was acceptable, and it was acceptable in all the 10 patients where the corticocancellous, because if it is a corticocancellous bone graft, we need to reshape it as per the size of the defect. So that is another challenge when we are doing the graft filling. And if you can see the uptake in 91.8%, it was there in the cancellous, and about 87.89%. And then the another thing was this is the very important study which is published in the literature. So from our study, we found that the cancellous bone graft harvesting was easier compared to the corticocancellous. Once you open up the trapdoor with the help of the bone scoop, the bone can be very well scooped. Cancellous bone can be like how we do the scooping of the ice cream. This aligns with the previous findings, which noted the less traumatic nature and rapid revascularization of the cancellous bone graft. Because the cancellous bone graft, there is a rapid revascularization. Previous studies encountered the challenges with the graft filling and the achieves adequate insertion of the the corticocancellous bone graft. Our study also observed the need for reshaping and the use of the additional cancellous bone graft for filling the corticocancellous bone. As I mentioned, the cortical bone needs to be properly reshaped, and which can be filled up with the cancellous bone, whatever the remaining defect where the cancellous bone. In this study, the bone bridge formation rate was observed to be faster in a group 1 patients than the group 2 patients. This indicates that the cancellous bone graft have a higher propensity for the rapid revascularization and the bone uptake, leading to the fast bone bridge formation. And that helps, and that is the reason many studies in the literature says the cancellous bone is comparatively much better for doing the alveolar core. The resorption rate of the bone graft was found to be slower in the group 2 patients compared to the group 1 patient. In group 1, initially there was a more resorption, but as the patient gets settled down, and that's the reason why I mentioned that we need to do the overfilling, especially when we are using the cancellous bone graft. This suggests that the corticocancellous bone grafts, although slower to incorporate, shows the resistance to the soft tissue contraction and prevents the excessive resorption, where the cancellous bone graft acts much more to that particular soft tissue contraction, leading to the initial resorption, but the uptake and the revascularization is very fast with the cancellous bone. Now, what are the protocols or the evolutions of the protocols we came across these 26 years is the early experience. As I mentioned, when we are the young enthusiastic surgeons, the decisions which were taken, and as we grow, we become more mature, and when to operate and when not to operate is the very important thing, and that gives exactly the early experience and the mature surgical expertise experience to decide the type of the grafting, the type of the bone, the type of the surgical protocol. Changes in the timing is another very important thing. And especially in India, it also depends upon the time of presentation of the patient to the clinician, to the surgeons. advances in the imaging. As you saw in my presentation, initially it was only 2D by using the different X-rays, but now for every patient, usually we do the 3D protocol, and the improvement in the surgical techniques as we mature, the surgical techniques also got improved, and the recent protocols for the management of the alveolar cleft grafting are used nowadays for the management of these two patients. So it made us the more learned surgeons to take the proper decision for this. So today we don't do any more primary bone grafting because the results are not much favorable, where most of our patients with the primary bone grafting had to undergo for the secondary alveolar bone grafting after 7 to 9 years of the age. So iliac crest bone grafting is a routinely performed procedure for alveolar cleft deformity in our. Now, if we see the literature, the Abhay et al. Highlighted the fundamental differences between the cancellous and the corticocancellous bone graft. The Muke and the Harman, the corticocancellous bone graft, provides the more stability and the rest resorptions compared to the cancellous bone graft. As I mentioned, the initial stage, the cancellous bone graft is there is a resorption, but as it starts revascularization, the uptake is very, very good and much high. So various study present in the literature for the volumetric assessment of the cleft defect and the cancellous iliac bone cleft grafting. The present the study concludes that the corticocancellous bone graft is comparable to the cancellous bone graft in the term of its effectiveness, despite of having its a few drawbacks. One advantage of the corticocancellous bone graft is it's a lower rate of resorption compared to the cancellous. This is the characteristics of the particular beneficial when aesthetic is concerned, as a corticocancellous bone resists the soft tissue contraction. And as I told you, when there is a need for the upliftment of the lifting of the LR base to have a stable results for the rhinoplasty procedures, the corticocancellous bone graft is more advisable. But when it is 9 years of the age, when the teeth is starting eruption, the cancellous bone is more advisable in all those patients. Although the corticocancellous bone graft takes longer to resorb, it allows for the equal tooth movement compared to the cancellous bone. In other words, equal use of the cancellous and the corticocancellous bone can be recommended for the management of the alveolar cleft defects, but we have to be very wise when to use the cancellous and when to use the corticocancellous is the ultimate decision of the surgeon and his experience in his previous. The flap design is mainly dependent on the size, the type, and the area and the shape of the cleft. Okay, as I mentioned, every cleft is different. Not every cleft is similar. Every cleft is different in its size, in its shape. Okay, so every flap has its advantages and disadvantages. But in our most of our patients, 90% of patients, we use the gingivo-cervical crevicular incisions, and the flaps were raised on the labial side, on the palatal side. Then the flap was transposed on the non-affected side, and that is how the primary closure was achieved in all those patients. The important points to consider are creating a mucoperiosteal flap that can be adequately elevated and that can be used for the proper sealing of that particular defect or the proper closure of that particular defect, producing producing without producing any tension in that particular soft tissue, because we need to have a proper soft tissue cover where there is no tension amongst those particular flaps. Okay. In addition, it is also important to achieve a sufficient cover over the grafted bone, particularly to ensure that the graft will not be exposed. This is another very important thing when we are doing the closure. So we have to have a proper soft tissue closure. The graft will not be exposed. But in our patients, around 2 to 3% of the patients, around 5 to 7 patients, maybe which the percentage about 4 to 5%, where there was a need to redo the procedures because of the exposure of those grafts, because of the soft tissue tensions or the improper closure of those soft tissue covers. The patients who were more than 12 years old attended the bone continuity and the healing without any graft rejection or the complications in our study. Therefore, these patients achieved a stabilization of the maxillary arch. This study shows that undergoing the alveolar bone graft at a later stage can still produce the good results and is considered a success. As I mentioned, the tertiary bone grafting, the concept of tertiary bone grafting, and the patients with the bilateral cleft should be informed about their specific risk for post-operative complications, losing a noticeable amount of the bone from a graft, or even the need for the reoperations. Especially when it is a bilateral cleft, the decision is up to the surgeon whether to do one side first and then go for the second side, or both sides can be done together. That also depends upon the decision depends upon the surgeon to surgeon and from patient to patient and the type of the alveolar defect which is present. So we have to be very particular, especially when it is a bilateral alveolar cleft grafting planning for the surgical procedures. Okay. So these are a few of the publications, as I mentioned in my presentation, regarding the three-dimensional use of the volumetric assessment, comparative assessment, ease harvesting, and the accuracy in topmost journals of the maxillofacial and the plastic surgery. I once again thank you for giving me this particular opportunity. Thank you so much for your patient listening. Thank you.
Thank you, Professor Datarkar, for your amazing lecture on your methodology for alveolar bone grafting. Now, we'd like to proceed on to our panel discussion. So the first panelist that I'd like to invite is Professor Honda.
Okay, Dr. Datarkar, thank you very much for the lecture. I have one question regarding the timing of the surgery.
Right.
Yes. Currently, I prefer to do alveolar bone grafting as a early secondary bone grafting. That means about the 5 to 6 years old of age.
Yes. Yeah.
The reason is that the patient do not before they are entering the primary school, so that they don't use the vacation period for during the school age, and
Right.
also we can start the also don't movement more earlier. So how about your impression regarding the early secondary bone grafting?
As I mentioned, not many patients were done with the early secondary. We did the grafting when the tooth starts erupting into that particular alveolus. So in most of our patients, we did that particular protocol. But doing the early primary grafting is a very, very good idea, especially as I mentioned we used to do the primary graftings. The idea behind that was before the child start going to the school, all the three surgical procedures should be finished. But the results were not very encouraging in our primary grafting. That's the reason we stopped doing it since last almost 15 years now. But early secondary bone grafting can be another very good idea for doing the grafting in alveolar cleft. How much is the take up of those early secondary grafting? If you can share with us, I think that will be very helpful for us, specifically the take up of that particular graft.
Oh, thank you very much. You mean the graft rate?
Sorry? Graft take
Excuse me.
up. As
Sorry,
you said, you are doing the early secondary grafting. So
yes.
how is the result of that? If you can share with us, I think.
Yes. I don't have an exact number of the grafting success rate, but yeah, I think it's equal to the normal secondary bone grafting. That means 8 to 10 years old age grafting. So we prefer to use the early secondary bone grafting.
But
Thank you.
does it have any effect on the growth of the maxilla?
Yes. Currently, we don't have any growth disturbance of the maxilla,
Okay.
so that I don't think that is a problem now.
So, thank you.
Thank you very much.
Okay, thank you, Professor Honda. Next, I'd like to invite Professor Sukarn.
Okay, thank you, Professor Datarkar, for your really insightful lecture, and really congratulations to the result and a very high amount of the number of the patient according to your presentation. From your presentation, you mentioned about the technique of you harvesting of the iliac crest bone graft, and that's quite different from our technique in Thailand. We normally use the cancerous bone graft by using the thread fiber harvesting from the iliac crest, and then we use Actually, around 80% of my cases, we used only canceled bone graft inside the aura cleft. But you mentioned about the clamshell technique, the trapdoor technique.
Trapdoor.
Yes, many technique. I would like to ask about which technique that you use the most and
In
why you use that.
in most of our patients, as I mentioned in my presentation also during the video, I use the trapdoor. The lateral trap, you prepare it, shift that crest towards the medial side, and just scoop out whatever the amount of the bone you want, and then the crest can be again repositioned, suture up the periosteum, so there will not be the growth disturbances in those particular patients, and that was the reason we used the trapdoor.
Okay, thank you. And what about the other graph you mentioned on this I think first slide that there are some kind of allographic material and xenograft. Do you experience that graph in our cave bone grafting?
Xeno we have not used at all. But we did the combination of the tooth as a bone graft, as I have shown you the cases, where some amount of the alloplastic material was mixed with that. Say like 70% of the tooth as a bone graft and the 30% was the alloplast, because the volume of the bone which we wanted to do that particular procedure or to fill that alveolar cleft was not sufficient with those particular teeth. And that's the reason we have to add some alloplastic materials. The results are good with if it is combined, but the only alloplast or the xenografts which we have not used in our experience since last 20-25 years.
And with the tooth bone graft, a tooth graft, do you experience any problem in tooth movement? Did your orthodontist talking about difficulty in tooth movement due to the
Not at all,
particle
not
of
at all.
that tooth?
No,
Wow.
not at all. The tooth is the dentinal tubules. They actually are very good source for the bone morphogenic protein and the other growth derived factors. And they really help us for a better osteoblastic jumping and formation of the a very good amount of the bone. So we did a study where a small amount of the bone after 1.5 years was harvested from the alveolus, where the tooth was used as a graft, and there was a very nice formation of the corticocancellous bone in that particular case.
Mm. Oh, okay. And the last question is about the bilateral cleft. You mentioned that we need to like discuss to the patient and selection depend on the difficulty of the cases which we use we do the stage surgery or we do both sides on the same
Yeah.
time. And what about your experience?
Yeah, I as I mentioned, it depends upon what is the type of the bilateral cleft present. Many patients they come where the arches are already collapsed and the premaxilla is protruding, especially when it is a bilateral. Okay, so in those type of the cases, with the help of the orthodontist, we discuss with the patients, and a stage surgical protocol usually is followed rather than going for a one stage surgery. But if it is a cleft where the arches are already in the maxilla is already in a arch form, where the premaxilla and both the maxillas are in a normal form, there a single stage grafting also is done in our series of the cases.
Okay, thank you
And the
very much.
volume of the bone needed is
Mm,
comparatively more if it is a bilateral. So the
mm,
donor site morbidity can be more if it is a bilateral alveolar cleft.
Okay, thank you.
Thank you so much.
Thank you, Professor Sukarn. Next, I'd like to invite Professor Lu.
Hi, Professor. I think it's a very good educational speech, and I learned a lot from
Thank you so
you.
much. Thank you so much.
So, do you have any like trick to suture the deepest side of the nasal floor when you do the nasal floor repair?
Very good question. So it's very challenging to do the nasal floor reconstruction before we do the grafting. So usually I prefer three 3/8 needle, which can be having a very good curvature and which can get rotated properly, especially when it is a deeper closure of the floor of the nose. So I use personally 3/8 curvature needle, which is very good, which is working very good in my hands for the, and obviously we use the vicryls for the closure.
Mm. So it's like use 3/0 or 5/0 suture.
3/8.
3/0.
So if you divide a circle in 8, so usually 5 will be the size of the needle, and that will have a very good movement for the rotation of that particular, so which can go into the deep and come out to a proper knot of that particular. But it's a very challenging and initial phase, especially when started doing it. It was very challenging for us, and it's a very steep learning curve. But the plastic surgeon with whom I used to work, he is a very senior surgeon, and he was master in doing those type of the closures. So I learned from him only how to do the closure of that particular nasal floor in the alveolar clefts.
Okay, thank you very much.
Thank you, Professor Lu. Next, we'll move on to our Q&A session. And today we have a lot of questions from our audience, so we'll ask these questions one by one. First question is from Dr. Hussein, and his question is, before bone grafting procedure, what are your expectations from an orthodontist for preferred tooth position that is near the cleft area?
The expectations from the orthodontist?
Yeah. What do you expect from the orthodontist?
Yeah. As I mentioned in my presentation, I already talked about this. Whether after doing the surgical procedures and the post-surgical orthodontics, what is the possibility of opening of that particular alveolar cleft is the most important thing. And if the orthodontist is sure about that, the cleft is not going to open, especially when they are doing the expansions. I think that is the most important expectation from the orthodontist as far as my surgical protocols are concerned.
And our next question is from Dr. Rosalie, and the question is, in cases where the bone is exposed 1 week after bone grafting, what is the best management?
If the bone is exposed, that depend upon how much is the amount of exposure which is present over there. Okay. If the tissue is under tension and there is an exposure, and if you think that it is further going to get exposed in subsequently after 2 weeks, 3 weeks, 4 weeks, then that is a real challenge for us. But if the exposure is not very big, very small, usually what we do in few cases, we did the resuturing where the tissue tension was not there. And in few cases, continuous irrigations with the saline and the maintenance of the oral hygiene, which helped us in getting the uptake of that particular bone graft. But if the exposure is high, 90% possibility that the grafting is going to fail in that particular. If the exposure is big, I mean to say, the possibility of the rejection of the graft is much, much high in that particular case.
And our next question is from PY. And his question is, in your opinion, can GPP replace ABG to activate bone formation?
Yeah, very good question, actually. The GPP is another technique which is usually done during the early periods. But the indication for the GPP is the distance in between two alveoli has to be very, very less. If the osteoblastic jumping distance is available there, say 2 millimeters, 3 millimeters, the gingivoperioplasty also can be an excellent surgical intervention where the need for the harvesting the iliac crest or touching the iliac crest or the other sides can be totally avoided. And it is really a good technique when it is done properly with the minimum surgical interventions, and the post-surgical fibrosis and the other problems of the growth disturbances are also not there if we do the GPP. But the only requirement is the osteoblastic jumping distance has to be there, which is about 2 to 3 millimeters. If the cleft is more than that, GPP is not going to work in those particular cases.
Okay. And our next question is, how many turns per day do you activate your distractor device?
How many?
How many turns per day
Yeah.
do you activate your
It is the half turn every day, means 0.5 millimeters every day we do. If it is in Hyrex, okay. If we are using the Hyrex, especially into the case which we have shown you. But for the different distraction surgeries for maxilla, mandible, and the other things, the different the distraction protocols is used, ours are used. In this case, it was the half turn every day in our case for the closure of the wider alveolar cleft was done.
And our next question is from Dr. Anumesh. And the question is, I want to know your experience with deep clefts where the volume might be more than some others. Do you use other tissues like fat for closure? Or if the soft tissue closure are difficult, do you use any fascia or collagen fibers?
No, not I don't have any experience of using the fats or other things. And I told you, when there is a wider cleft, usually we try to bring them together and then go for the surgical procedures.
Okay. And our next question is from Dr. Alfar. And the question is, in your experience, what are the main factors that might lead to bone graft failure?
What are the main factors?
That might lead to bone graft failure.
Oh, the most important is the exposure during the healing time. Okay. If the tissues are not properly closed, that is the very important thing. And the second very common reason is if the nasal floor is not properly sutured and there is a leak of the nasal secretions from that. So these are the two very important factors which can lead to the infection of that graft and subsequently leading to the failures.
Oh, and actually our last question is from Dr. Anoop. And the question is, do you ask your orthodontist for full arch treatment or sectional orthodontic around the cleft area?
Sorry?
Do you ask your orthodontist for full arch treatment or only sectional orthodontic treatment?
Full arch management.
Okay.
We need to do the full arch management. Okay. So depending upon the requirement of the orthodontist and the requirement of the surgeons, the cases are planned.
Okay. And our last question from PY is, have you applied any BMPs to your cases?
The BMP can be a very good option for the alveolar bone grafts, but the cost is very, very high in India. Okay. So that's the reason why I don't use BMP or I don't have much experience of using the BMPs. But there are few centers where the BMPs are also used for the management of the alveolar cleft. But because of the cost, the affordability of the patient, I have not used in my center.
Do you think there's any indications where these materials might be helpful? Any particular?
Obviously, BMP stimulates the revascularization and regeneration of the bone graft. And if it is combined with the cancellous bone, I think that can give the 100% acceptance of the lesser resorption, more faster remineralization, revascularization, mineralization, and formation of a nice bone can be achieved by you adding the bone morphogenic proteins with the grafts.
All right. Thank you so much for your presentation again today, and we'll turn the mic back to PY.
Thank you. Thank you, Dr. Datarkar, for your very comprehensive and with your long-term experience to using the alveolar bone grafting for the patient with the cleft alveolus. In Chang, our protocol is very similar to like yours. We apply the alveolar bone graft to treat all those patients with alveolar cleft as well. We harvest from the same donor site from the iliac bone as well. And we use the tripod technique to harvest the donor bone graft as well. So we have very lots of experience in common. And we do the bilateral cases. We could do it in stage, and we could do it simultaneously. And currently in our protocol, our experience show if we do the bilateral cases at the same time, the survival rate and the bone survival rate is very similar to we stage it to do the two stage of bone grafting. The survival rate is almost the same. And like the Professor Lu asked the question, how we could figure out the most deepest site in between the oral and the nasal. Like Professor Datarkar, you use a 3-0 vicryl to treat because you have a special angle, and with your special technique, you can very well repair the difficult part, and has a very nice repair to isolate the oral.
But it's a very steep learning curve.
Yeah, that's very nice. And currently in our center, we try to harvest additional one of the fascia graft. And that one is that additionally, we could suture it over layer. It's kind of a barrier. So before it be resorpted, I believe that could a very nice barrier to help the bone graft survival in the first 7 days after the bone grafting procedure to facilitate the bone formation. So it's our protocol. So it's a little bit different, but our survival rate is okay, it's good as well. Okay, so we very thank you for your sharing. Very nice 25 years of a bone grafting procedure. And we have 3 very valuable panelists as well. Professor Sukan, Professor Handa, and Professor Tin Chen. Yeah, and I would like to invite all our audience from ICC to take a group photo. And by the way, I need to announce our next, the ICC, the 131, the webinar. And our next ICC webinar, the topic is clear aligner treatment feasible for children? Because compared to the clean aligner and the fixed appliance, which one is better and can get a nicer result for the children is still a controversial one. And our speaker is the Dr. Trung Ho from Vietnam. So looking forward to all our audience come participation next time. And our next time our ICC is the July 5th. So we have lots of a long time to take a break. So that's nice. And I would like to count to 3 and please give me a big smile and we can have a group photo with our speaker, Professor Datarkar, and our 3 valuable panelists as well. Oh, I see. Hi, Dr. Jia from Thailand. Hi, Dean. Hello, Kate. And Jia from Cambodia. Hello, Martin from your dormitory. Louis from India. No, Indonesia. Sorry. Hi, Ben from the Philippines. Hello, Ted, Nepal. Thank you so much. And 1, 2, cheers. Okay. Thank you very much. And see you next time. Good morning and good
Thank you
evening.
so much. Thank you so much
Thank
for
you.
opportunity.
Thank you very much.
Yeah.
Bye-bye.
Bye bye.
Bye-bye. Bye-bye. How to say?
Bye-bye.
Bye-bye. Okay, have a good night and have a good day. Thank you, Professor Sukan. Thank you, Yaya. Bye-bye.
Thank you very much.
Bye-bye.
Bye bye.
Have a good day.
Mm.
Bye-bye.